as you know, each week we begin with exercise because we say what's good for your heart is good for your brain. We want you moving. We want you active. You must stay engaged physically. Okay? All right. So with that said, remember you can use the Q&A function. We're so glad from last week, all of you that signed up with Divinity and Dr. Grabi and Dr. Clareshta for their research opportunity. They're going to be hosting 2 sessions in the upcoming Fridays. That's easy peasy. You do a consent form through RedCap, and that video has been loaded. So if you want to go back and see what you missed, you can head over to the YouTube channel and watch that video. All right. With that said, I think it's time to get moving. Remember, go at your own pace. John goes fast, he goes slow. He does a lot of stuff, and all of that energy comes through the screen. So welcome, John. Get our hearts going, get us pumping. Thank you guys for being here. And remember, go at your own pace, okay? So welcome, John. Thank you guys for being here.
Hey. First of all, I would like to welcome you to the Emory Alzheimer's Disease Research Center. Hey, all you men, all you women, please spread the word about men coming out and just getting the knowledge or awareness or just getting rebooted on information that we need. Please just tell loved ones, come on out. Tell the men, come on out. Y'all come together. Wives, grandmothers, aunties, tell those men to go get some awareness about their bodies and things they can do, not only for themselves, but for the community, so we can have a healthier lifestyle. Today, we're gonna take it a little slower today and really work on the details of abs, upper body, and I'm gonna get a little bit of that cardio. So let's go. If you have canned goods, water bottles, dumbbells, bands, go get them right now. Here we go. So I'm gonna use my threes today, threes. And if you don't have anything, just watch my form. We're gonna do incline chest press. Only 10 today. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. If you don't have anything, it's okay. Now we're gonna go in the middle of the chest, straight line, chest up, and let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Now we're gonna do a decline that's gonna work on the lower chest, but high shoulders. Elbows at an angle, and I'm gonna shoot down and pick up. Ready? Go. And we get a little bit of that upper back and upper lats. I'm gonna pull as I push down. 5, 4, 3, 2, and 1. If you want to get that outer chest, outer pec area, level arms, not here, not here, here. And you squeeze. Out, squeeze. 3, 4, 5, 6, 7, 8, 9, and 10. Good. I have my knees together. I'm gonna bend at the waist and my elbows out to the side. And as I go up, I'm not gonna let them go back. So I can get the upper low lats. Here we go, and let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Great job. Now, when I do a fly, I'm gonna bring it down like 7. So I'm gonna go boom. Now I'm gonna get those mid lats and outer chest. Here we go. Let's go. 1, 2, 3, 4. Squeeze it. 6, 7, 8, 9, 10. There we go. Okay, we're gonna get a little bit more difficult. I'm gonna lean back at an angle, hands at an angle, and straight arm fly. Y'all ready? Let's go. 1, 2, 3, 4, 5, job. Now for the biceps. I put my knees here and I'm gonna squeeze. Squeeze. Even if you don't have any resistance, squeeze it. Squeeze. 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 Squeeze it now. Squeeze. Squeeze. And squeeze. Good. Everyone asked me about the triceps. All right? Elbow up and you squeeze. Don't let the elbow go up and down. Keep it up level and squeeze. Squeeze. Look at the line. Squeeze. 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 There we go. Squeeze. Squeeze. And squeeze. For the other one, we're going to do it a different way. I want your elbow here, and we get to the top and squeeze. Here we go. Squeeze. 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 Bring that arm out. Squeeze. Squeeze. 5 more. Let's go. 1, 2, 3, 4, and 5. Great job. We just touched a little bit of that upper body, but now let's get that waistline. Okay, sit up straight, feet wider. We're gonna take our time. We're gonna get the side obliques. Right here. If you have any back problems, we also loosening that back up because we making both of those muscles contract. Now we're gonna just lean forward. My chest is still up and left to right. Okay, now we just gonna go lean back. There we go. Now I want your body sitting up. Turn. Turn. Nice and smooth. There we go. Chest up. Remember, we're taking it slow today. There we go. Crunch, 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 crunch. I want to twist with a crunch, 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 crunch. Stay in the middle. Crunch, crunch, crunch. Come on, crunch, 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 crunch. Now, just hang over here, crunch, crunch. Lean and crunch, crunch, crunch. Other side, let's go. Crunch, 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 crunch. Let's crunch, 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 crunch. Good. Now let's get these lower abs. I'm leaning back just a little bit. Now we're getting those lower abs to mid abs. Crunch, crunch. Nice and smooth. Crunch. Press. Other leg. Let's go. There we go. Keep it going. Press. Watch it now. Both legs coming up. Let's go. Come on now. Press. There we go. Now I need those outer lower obliques. Right here in the love handle. Foot wide. Hands here. Right here. Crunch. 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 job. I need to finish y'all off with some cardio. Here we go. Woo! Calling all dancers. Good for you. Live it up. Let's go. Let's finish. Let's go. Come on. I'm on that waistline. Oh, we going. We going. We going. Going. Go. 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 Rest. Come on. We almost done. Let's go. Let's go. Go. Watch it. Go. Five, 4, 3, 2, 1. 10 seconds and we done. Y'all ready? 1, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hey, I enjoyed you. Remember, tell a male about the health awareness that we're going to give them the knowledge and a reboot. I know they know everything, so let's reboot them and learn something at the same time. I'm John Lewis, and see you later. Bye.
Bravo, bravo, bravo. Yes. Thank you, John. Kudos to you. We appreciate him coming on every Tuesday. He has not missed a Tuesday, you all. We appreciate him for coming live with us. Yes, thank you for your comments. Someone said, great job. Awesome workout. Thanks, John. We see all of your feedback every week. We appreciate each and every viewer, and I hope you're not out of breath, but you are a little winded, right? So we promote exercise. It's what we refer to as neuroprotective. So hats off to John and to each and every one of you who, if you're staying active, you're doing your body justice. All right, so Dr. Parker, come on in. Welcome everyone. She was in San Diego last week presenting some great information about all of our work as a core funded through the National Institutes of Health. We had an opportunity to collaborate and meet colleagues that we work with from a scientific perspective. So not only are we bringing you all great information every week, but we're working behind the scenes to collaborate with partners literally from all over the world. So that was the opportunity at the Alzheimer's Association International Conference that was held in San Diego last week. Dr. Parker, welcome.
Thank you, Cornelia. And I know you all can't see my face, but I'm having some issues here, but you will hear a great program today. We're bringing Dr. Sharonne Hayes from the Mayo Clinic, who's going to talk to us about heart disease and how it affects us. And also Dr. Erik Johnson, who is one of our clinical neurologists here at the Emory Cognitive Neurology Department in Emory Healthcare. So without any further glitches, you will hear next from Dr. Sharonne Hayes, followed by Dr. Erik Johnson.
I'm going to show a few slides, so I'm going to share my screen here as we go forward. Let me just pull this over here. So one of the things that I have spent, well, gosh, over 2 decades, sort of focusing on sex and gender differences in heart disease. And I'm going to share a little bit about that. But the one point I'd like to make is, and the title of the talk today is, women are not small men when it comes to cardiovascular disease or their risks or prevention. A lot of overlap, But that very assumption that we could include just men in research and then apply the results to women, or that women didn't get heart attacks for that matter. And that was until the 70s was really one of the things that people thought. Well, those we know are untrue, and they actually harmed women. So this is one of my favorite editorial cartoons. It's actually related to a study that was published many years ago. But what they did, as they often do to see are there differences, is they took black and white men and black and white women, and they gave doctors a scenario which should have led to most of them being referred to a cardiologist. It wasn't a slam dunk, but black women followed by white women were the least likely to be referred for further evaluation of chest pain symptoms. And so, if we look at the data, and I am not going to wax on because I think we're going to focus on solutions today, but there really have been multiple disparities identified and differences. So disparities, by that I mean later diagnosis of a heart attack, worse outcomes with heart failure treatment, more undiagnosed heart disease in women. And if we say that's women in general, women of color, women who do not speak English, so those who have any extra barrier to care have even more of these things. So some of these are failure of the system to not investigating, including women in research. And some of it has to do with some of the biases that heart disease doesn't happen to women, or it doesn't happen to young women, or if you look healthy, you can't have a heart attack. So all of these things have led to where we are today, which is a lot better than we were 20 years ago. I wanted to introduce a couple of topics because some of you may not know the difference between sex and gender or use them interchangeably. It's important because within heart disease, cardiovascular disease, probably stroke, and Alzheimer's too, there are both sex differences, and that is biological difference. So every cell has a sex. So that means differences in anatomy, physiology, hormones, genetics. But then there's gender, and gender is really that self-identity or social representation. So it's the psychological, social, it's what shapes us culturally and behaviorally. And so at the same time we say, well, women can have babies and men don't. We can also say there are some things that tend to be more feminine in our culture that can affect how we are diagnosed with heart disease, how we express heart disease, and our risk factors as well. So I'm going to give you an example of perhaps gender difference. So a study was done that only about half of women said, I would call 911 if they were experiencing heart attack symptoms. So they knew what the symptoms were, and they said, it was only about a 50-50 chance I would call. But 80% said they would call 911 if someone else was having that heart attack. And of those women, about half of them said they do something else. They take an aspirin, they drive themselves in the middle of a heart attack going to the hospital, or call their doctor. So that's not a sex difference. That is actually a gender difference. And when they dug further into this, some of the women said, oh gosh, I'd be so embarrassed if I got to the hospital and they said it was just indigestion. So I think women culturally, so more gender, may say, I need to take care of other people less than myself. So I want to plant that little seed. And I wouldn't do my job as somebody who was presenting on heart attacks, even though we're not going to talk about heart attacks, but knowing what the most common symptoms of a heart attack are, because that is an emergency for which you call 911 and you do not drive yourself. The most common symptom for men and women is chest pain or discomfort in the upper chest, squeezing, pressure. But women, more commonly than men, but both can get both, any other pain in the upper body, jaw, neck, upper stomach, or between the shoulder blades, shortness of breath. Women are more likely to have nausea and vomiting, think they have the stomach flu, profound fatigue, a cold sweat, or lightheadedness. So these are the ones that we want you to call 911 and get help. But we're going to talk more about prevention and some of those sex differences. One of the reasons, there are actually some different risk factors for women and men for having a heart attack. So women have different experiences. One, they have the lifetime hormonal fluxes, puberty, pregnancy, menopause. When women are pregnant, their uterus goes from about the size of a fist to real big and then back down. That means they can grow new blood vessels. Women can have hypertension and diabetes during pregnancy and other things like delivering a very thin or small baby or preterm baby. They have the hormones that they take, oral contraceptives and postmenopausal. They are more prone to autoimmune conditions and sex-specific effects of risk factors. So they may have the same risk factor that is more or less effective. So you can see some of these are things that only happen to women. They are unique to women, and that's why it's important to consider sex. So here's the risk factors. On the left side, these are the traditional atherosclerotic cardiovascular disease risk factors. Men and women share them. What's different if we take diabetes, for instance? Diabetes in women compared to men is actually increases their risk of heart disease more. So the presence, for instance, for a given dose of smoking, like a half pack a day, women are more likely to get a heart attack or stroke than men for the same reason. So although the risk factors are the same, they may give more weight. Now, on the right side are those risk factors that are unique to women or much more common in women. So we talked about conditions of pregnancy, and I'm going to dig a little deeper in that because that's something I want all of you who've ever had a pregnancy to remember and share with your doctor. But women are more likely to have autoimmune conditions like lupus or rheumatoid arthritis, which increases inflammation and their risk for heart disease. Cancer treatments of all type, but particularly breast cancer treatment, both the drugs and irradiation of the chest and the heart can increase the risk of heart disease in women. Women are more likely, twice as likely as men, to experience depression, which is a risk for heart disease. And early menopause, whether it's surgical or natural, can also, because it deprives women of those hormones, increases the risk. So it's not just heart disease where we see different weights of risk factors. In this paper that was just published in February of this year, they looked at risk factors, and for stroke risk, diabetes, high blood pressure, obesity, atrial fibrillation, and migraine with aura in women really was a much greater risk factor for stroke than those same factors in men. So that's why we need to consider sex and gender. So I did want to focus a bit more into pregnancy because that is one that is only in women. So we used to think, we've known for a long time, if somebody has high blood pressure or preeclampsia during pregnancy, that they will have future risk of heart disease or high blood pressure. And initially we thought the cause and effect was, they had this in pregnancy and that caused it later. But actually what we have learned is pregnancy is actually a metabolic stress test. And the woman who's perhaps it tips their hand, they flunk that stress test by getting high blood pressure or diabetes or not growing a full-term baby, or their baby is very small. Other risks related to pregnancy are infertility and infertility treatment, polycystic ovary syndrome, and advanced maternal age. And so if any of these are present, that can increase by 2 to 3 times the risk of subsequent cardiovascular disease, whether that's high blood pressure, blood clots, kidney disease, heart failure, arrhythmias, or blockages in the arteries, stroke. And there is an impact because babies who are present in that environment, the fetus, in that environment actually seem to have a higher risk of some of those things too later on, which is why early detection and treatment of these. So those are some of the differences that we've seen. Now, those first 7 on the list in this slide, you may be familiar with. They are the American Heart Association's Life Simple 7 goals for both behaviors and for managing risk factors. So not smoking, being a healthy weight, exercising regularly, eating a healthy diet, lots of fruits and vegetables, making sure our blood pressure and cholesterol and blood sugar are at good levels. What I'd like to do is add for women, know your risks, particularly those that are sex or gender specific. Those pregnancy risk if you have an autoimmune condition. So being aware of those and talking to your doctor. Now, we've been recommending to cardiologists that they take a pregnancy history for women for a number of years, but we know that they are not doing so. even though it's a very powerful risk factor. So the next time if you're a woman and you know that you had preeclampsia or preterm birth, mention that and get that in your medical history. And the other heart there is to follow the recommendations. Here's just sort of a diagram of when we say primary prevention, that's really what we're talking about. For those of you in the audience who don't have cardiovascular disease, don't have stroke, we're looking to keep it that way. So we want to look at risk, we want to look at behaviors and keep doing that Life Simple 7. For those of you who have high blood pressure or other things, we want to confirm the diagnosis and treat it. And if you've already had a stroke or a heart attack or some other diagnosis, then moving forward. I started this talk by talking about why we're behind the 8 ball for women and why sometimes I have to say to my women patients, I don't know, I'm not as sure as I would be if you were a man with the same condition, or the medicines or the tests have not been. And that's because in cardiovascular research, even today, less than 5% of individuals who are involved in research are minorities, and about a quarter are women. And even when they do participate, reporting it out by sex and race ethnicity is an exception. And so what we're forced to do sometimes is making medical decisions for patients for which we do not have all the data. And this can lead to over or under treatment. It can lead to higher cost. And particularly if I prescribe a medication to someone for which it either doesn't work or causes unpredictable side effects, they may not use the medication. So this is just a plug for you to support research, and I know you are by being a part of this program, participation in all of these things to help our knowledge so that we are not excluded. So to summarize, if we're really looking about reducing the burden of cardiovascular disease in women, and they are not small men, we want to look at these sex and gender differences, the physiology, the outcomes, look at disparities, look at the basic science data so that we can make better decisions and care, making sure that we pay attention to pregnancy health. And if somebody has a complicated pregnancy or fails that pregnancy stress test, that they get some follow-up, a little closer observation for blood pressure, supporting people's psychosocial and cultural needs, and making sure that we reach the people that are most impacted. We need to invest in women's health research and including women, especially women of color, in that research. And then for all of us in healthcare, making sure that we disseminate and employ our best practices and guidelines, which hopefully will be built on the research that you'll all participate in.
Okay. Yeah, so Dr. Parker is going to continue to respond to your questions in the chat if you want to post those while we transition over to Dr. Erik Johnson, who's going to be talking about biomarkers. You've heard that word many times, and now he's going to be able to explain to you what it means and the significance of biomarkers as it relates to dementia and Alzheimer's. Welcome, Dr. Johnson.
So I'm going to talk a little bit about biomarkers for Alzheimer's disease, specifically blood-based biomarkers. So what is a biomarker, first of all? Biomarker is just something that measures something that's going on in your body. Okay, it could be really any type of measurement. It could be an imaging test. It could be a blood test. It could be something where we're measuring, electrical activity, anything that can really give us a sense into what's going on in the body. I don't have any disclosures to make for this talk, just to be clear. All right, next slide. So just talking a little bit about Alzheimer's disease, first of all. Alzheimer was a physician in the early 1900s in Germany who saw a patient. Her name was Augusta Dater, and she actually was admitted to the hospital that Alzheimer was working in at that time. He was a psychiatrist, so he was working in a mental institution, an insane asylum, and in Germany at that time. And in those days, most of the patients that were admitted to those type of facilities were actually suffering from complications of untreated syphilis, because there wasn't a treatment for that back then, and a lot of people had that disease. But that Alzheimer noted that this patient was a little different from his other patients that he saw, and she had a lot of memory problems. And so he took an interest in her. And when she died in 1906, he actually took a look at her brain under the microscope to better understand what was causing her symptoms. And he used some new techniques of the day to look for different types of pathologies in the brain that were not available before. And he noticed these things called plaques and tangles. That's what he called them, plaques and tangles. And this was very interesting to him. He actually wrote this up and described it, and it went into the textbooks. But it wasn't studied that well over the 20th century because a lot of people, didn't live long enough necessarily to develop Alzheimer's disease. Well, of course, that's changed now. These days that people are living longer and more people are having memory problems that are caused by Alzheimer's disease. So, but these are still the two cardinal pathologies that we use to define Alzheimer's disease, these plaques and tangles. And you have to have these in the brain in order to have a diagnosis of Alzheimer's disease. Of course, the problem is how do we know that someone has these in the brain if they have memory problems? We don't take tissue out of the brain and look at it underneath the microscope when people are alive. So we have to have different ways to assess whether there is plaques or tangles in the brain. Next slide, please. So how can we do that? So what about imaging tests? Can we look at it? Can we look at the brain and see these plaques and tangles with different imaging tests? Well, what about CT scans? CT scans are good for looking at things that are hard, like bones, or things that have iron in them, like blood. They're not so good for looking at soft tissue, and they don't really tell us anything about the pathology that's within the brain, these plaques and tangles. So no, we can't use CT scans to see whether or not someone has plaques and tangles. What about MRI scans? Well, MRIs are much better at looking at the soft tissue of the brain. We can see a lot more detail compared to a CT scan on an MRI of things that are going on in the brain. For instance, vascular disease. We can oftentimes see whether someone is having a lot of vascular problems from hypertension or if they had a stroke in the past or recently. Unfortunately, we can't observe plaques and tangles with an MRI scan. We can look at the structure of the brain, we can look at different things like the blood vessels, but we can't really see this pathology in the brain, unfortunately. So we can't use MRI scans. So what about PET scans? You may have heard of a PET scan before. A lot of times people get PET scans if they have cancer, and they're people looking for tumors. So we actually can look for plaques and more recently tangles with a PET scan. What that involves is getting an injection of a compound into the blood that travels to the brain and then binds to these plaques. And this compound is radioactive. So it emits a signal, and then we can detect that signal when it binds to a plaque with the PET scanner. So we can image plaques with PET scans and tangles now too at a research level. But unfortunately, this is very expensive to do. It's quite time consuming, and it involves quite a bit of exposure to radiation. First, you have to get a CT scan, and then you have to get the radioactivity injected and image these plaques in the brain with a PET scan. So we prefer not to do that. Of course, sometimes people just have to get CT scans, and there's some radiation involved there. But it's not an ideal way to really be able to screen people to see whether they have amyloid or tau, these plaques and tangles in the brain. So what about fluids? Can we look at fluids? Well, we actually can look at spinal fluid through something called a lumbar puncture to see whether or not they have changes in the spinal fluid that would reflect these plaques and tangles, these protein biomarkers. The problem with lumbar punctures is that, of course, they're invasive. They involve a needle in the lower spine. And they take some time to perform in the office. And unfortunately, they're really not widely available. It's more of a specialty procedure. Most general practitioners or internists don't perform lumbar punctures in the office. So the availability is quite limited for this type of approach. We do this here very often at Emory in the cognitive clinic, but it's not something that's done as often in the community. Next slide, please. So what about blood? That blood would really be an ideal way to test for plaques and tangles, just like it is to test for, say, cholesterol. So it's easy, relatively easy to draw blood. It's accessible in terms of drawing the blood, but also, you can get this done in a primary care office or an internist's office. It's quick and theoretically relatively inexpensive. What are the challenges? Why don't we have a blood test for Alzheimer's disease for these plaques and tangles in the brain? Well, it's turned out to be very challenging to measure this pathology in the brain, in the blood. And that's because of something we call signal to noise. And just let me explain what I mean by that. So a signal is something that we're interested in measuring that reflects a plaque or a tangle in the brain, right? Some kind of pathology. That's what we want to measure. But then there's the noise component. And noise could be due to many different things. So for instance, noise could be due to changes in your blood that are due to what you ate last night or for breakfast this morning, because blood's highly variable to what you eat. It could be due to other things that are going on in your body. For instance, if you have an infection or you have some other kind of other disease process like arthritis in your body that can affect levels of proteins in the blood in different people. It could be that the blood has sat around for an extra few minutes in the tube and has clotted off, or the enzymes in the blood have started to chew up the proteins that are there when they're not in the body anymore. So noise could be due to many different things, and that's really been a challenge to measure brain pathology, because the brain is a privileged organ in the body. It's not like the liver. The body is actually restricting access to the brain from the blood very specifically because you have to keep out a lot of things that you eat and things that are away from the brain. So it's a privileged organ, and it's hard to get that signal into the body and measure that. So that's been the challenge. But there's been some great progress. Next slide, please. In developing a blood test for these plaques, these amyloid beta plaques. And recently there's been a test that has received an FDA breakthrough device designation to test for amyloid plaques in the brain using a blood sample. It's not formally approved by the FDA yet, but it is fast-tracked through this breakthrough device so that it can be ordered. And it's indicated, it's called Precivity AD. It's actually a company that was spun out of Washington University in St. Louis. So the company is based in St. Louis. And it is meant to test for people that are having cognitive problems, at least 60 years old or greater. It costs quite a bit of money, $1,250, and unfortunately not covered by insurance at this time. So that is an out-of-pocket cost. It requires the test to be sent to that laboratory. They are the only ones in the world that can run this particular test. Okay, so it's a reference test, a referral lab test. If we draw it here at Emory, we would have to send it there and have them test it. And what they do is they use some special approaches and techniques, one called mass spectrometry and some antibodies, to really purify this amyloid beta protein from the blood and measure the levels in the blood. And then once they do that, they also use the patient's age and their ApoE genotype. We've talked a little bit about ApoE. It's the strongest risk factor, genetic risk factor for Alzheimer's. They use that information as well to calculate a probability score of whether or not someone has amyloid plaques in the brain. And that's what I'm showing over here on the right. So this is the probability score. One would be perfect probability that you have plaques, and 0 would be a 0% probability. And so here are a bunch of people that they tested that we know based on a PET scan have amyloid or not. So these people have amyloid in their brain. These people don't have amyloid in their brain. And then this is the model probability score from this particular test. And how does it perform? Well, if you set this cutoff level, say at about 0.4 or something here, then it does, fairly well. It captures people with low probability. Most of them don't have amyloid in the brain, and people with high probability, most of them do have amyloid in the brain. Of course, there are some people that don't fall into those two categories, and so it's not a perfect test. And what the company does, if you could just press one more forward, I'll show you, is that they set a confidence. So they don't say just one value. They say there's going to be a gray area in between here. And we're going to say between 0.3 and 0.5, we're going to recommend that you get some more tests done, for instance, because we're not as confident of what your status may be. But based on the studies so far of this particular test, that it looks to be about 90% accurate in saying whether someone has a high burden of amyloid plaque in the brain or not. And that is an improvement over, say, just looking at their ApoE status and their age, which actually isn't too bad. If you know that, you can get pretty high accuracy on whether someone has amyloid in the brain. And if you only look at this A-beta measurement, it's only 80% accurate. So when you put all this information together into a score, you can get it up to about 90%. So that's not too bad. And that's something that's under study. It is available right now. Again, it's kind of a new test. And we don't send that here at Emory right now, but there are some large studies going on where this test is being included in clinical trials to help with
Dr. Johnson,
yes.
This is an expensive test, much like the PET scan that we do here. Are we doing blood biomarker studies here at Emory that people can participate in?
Right. So we're doing a lot of biomarker research here at Emory, and the way that you can participate is by donating some of your blood if you're involved in any of our clinical studies here, or even if you're a patient. If you're willing to donate some blood, that's helpful for our research studies. We have Emory Healthy Brain Study or other clinical trials are also collecting blood as part of our biomarker research program. Next slide, please. So what about this other pathology called a tangle, these tau neurofibrillary tangles? You have to have these in the brain too to have a diagnosis of Alzheimer's disease. Well, it turns out that there is a form of this protein that can be measured in the blood and the spinal fluid, but more recently in blood, and it's called p-tau or phosphorylated tau. Your body kind of modifies this protein a little bit that we can detect. It's a little bit more specific for Alzheimer's disease. And there are a couple of different forms that are being studied. One is p-tau 181, where certain parts of the protein where this modification occurs on this tau protein. And at this point, this is really a research level only test. There's a lot of excitement around being able to measure tau in the blood because tau seems to correlate more strongly with cognitive symptoms than amyloid beta does. So we'd love to be able to measure tau, especially in the blood. It's research level only. The benefits is that of these particular tests, opposed to say what I just presented to you, this precision test, is that you can use standard lab techniques to measure it. So if we can work this out, any center that has a medical laboratory, in theory, could measure tau It doesn't have to be sent necessarily to a reference laboratory. And excitingly, it may be sensitive to both amyloid beta and tau, not just tau. So there is some evidence that when we measure this protein, it could reflect amyloid status as well in the brain. So it has the potential to have really high diagnostic accuracy and be easily measured. And it's, again, like I said, it's still research level only, but we may have a test within the next couple of years for tau that would be excellent for our clinical and research operations.
One of our things with our research, and many of our participants on this program, over 266 at last count, are women. And as Dr. Hayes pointed out, we need more women in research. We need to test whether these biomarker measurements for Alzheimer's are effective in women. So participating in our Emory Healthy Brain Study is one way to do that. And whether you have symptoms or not, we'd like you to participate in our research where we can test whether or not these biomarkers are effective. Again, we need you to participate in our brain aging studies, our biomarker studies that are here. And if you're a clinical patient, most likely the neurologist is going to ask you about these. So, Dr. Johnson, are there any specific studies that you want to direct our audience to?
So I think the Emory Healthy Brain Study would be a really helpful study for caregivers to enroll in. The Emory Healthy Brain Study is a study that is enrolling people that don't have cognitive problems, but often many of them have family members, for instance, that have Alzheimer's disease or other dementias. And we want to be able to kind of detect these changes as early as possible in patients, before they develop symptoms. We'd really love to be able to screen people to see whether they have amyloid or tau in the brain before they develop symptoms, because we think that our treatments are going to be most effective if we catch people that have these problems before potentially they're even having symptoms. That would be a preventative type of a therapy. That is where the field is going right now, and our hope is that we can try to get people before they end up coming to the clinic when they're having problems, because at that point there's a lot that's already happened in the brain to cause these cognitive problems. So the Emory Healthy Brain Study is one of an important study. And there are, other trials that we offer here through the clinic as well, if patients are having problems already with their memory.
Okay, so just to recap and be clear, Dr. Johnson, when you're making a diagnosis of Alzheimer's dementia, please give us the traditional way and what we're looking forward to in the future, because neither the FDA amyloid PET scan or these biomarkers are currently available or paid for by insurance, right?
That's right. And that's, of course, been a bit of a controversy in the field. We'd like to be able to order more tests that can look for amyloid and tau that are, easier to do. But of course, right now, the tests are quite expensive. They're hard to get. And they're not covered by insurance. Oftentimes, these tests will be covered if you're involved in a research study, right? So that's one way to actually get a PET scan, or some other test like this is to participate in a research study. But I think, again, if we can develop these blood tests that are lower cost, this Precivity's test is still quite expensive. So I don't know if insurance is going to cover it. We have the insurance companies, and like Medicare, government insurance, they want to see that if we order the test, that it changes something that we do in the clinic or for an individual. not just to have that information, but how does it change our management? And that's something that has to be demonstrated through clinical trials, is that it does change our management. For instance, what medications they may start or what kind of care they may receive down the road. So hopefully that, eventually these tests will become available. I'm optimistic within the next 3 to 5 years that we'll have a blood test that probably with tau is my guess, that we can order and see whether someone has the amyloid in the brain. And I think that'll be a very helpful and welcome development for the medical community, not just neurologists and cognitive neurologists in their office, but also for primary and care doctors and internists. Of course, it does also raise some questions on how we're going to use this test. How are we going to use this information that is provided by the test, and who will be tested for it? Are we going to be testing patients at this point that actually don't have any symptoms? I think, there's important questions that will be informed by available treatments that may come down the road soon, whether that's aducanumab or other potential therapies that are approved by the FDA, and that would change the testing paradigm.
Okay. All right. Thank you, Dr. Johnson. And just to reiterate, both the Precivity blood biomarker test that Dr. Johnson talked about is not available to clinicians right this moment. It's still being investigated for research. And more importantly, even if you get the test, it is not covered by your insurance, nor is the amyloid PET scan. So we're really actually trying to ask you in a nice way to participate in research, right, Dr. Johnson? Okay.
I think that is, yes, that's our really our real motivation. Our real ask is to really please participate so we can make some progress on these blood biomarkers.
And there is a question in Q&A I'd like you to answer, since you are a treating neurologist and doing the diagnoses. I'm understanding correctly that the CT scan or MRI are not really of value when trying to determine which type of dementia a person has?
Right. So CT scan, not so much, but MRIs are helpful when one is trying to make a diagnosis of the type of dementia. Not because we can't see amyloid and plaques, but really because sometimes there are certain changes in the brain, atrophy patterns, parts of the brain that lose tissue compared to other parts of the brain that can have some diagnostic value. And other things that we can see by MRI, for instance, blood products or vascular changes in the brain that are also helpful when trying to assess for, say, vascular dementia. So MRIs are particularly helpful in trying to make a diagnosis of the dementia type. But unfortunately, they can't tell you the amyloid or plaque burden in the brain. And so oftentimes, if there is still a question of whether this may or may not be Alzheimer's disease, then depending on the circumstance, we may move towards, say, a lumbar puncture to assess for those pathologies in the brain.
Thank you, Dr. Johnson. And let me just highlight one other question. I'm not sure how you can hear or see, but one of the questions that's in here is frontotemporal degeneration a form of Alzheimer's? I think this gets to different types of dementia.
Right. So we actually consider frontotemporal dementia as separate from Alzheimer's disease. It typically presents a little bit earlier in life than Alzheimer's. And if you look at the brains of individuals that have frontotemporal dementia, they have a certain atrophy pattern in the brain in the frontal and temporal lobes. And there are characteristic pathologies associated with frontotemporal dementia that are distinct from Alzheimer's disease pathologies. So we consider FTD or frontotemporal dementia as a separate disease, although there is some overlap in the way that the brain changes occur in both diseases.
Okay. There is one last question. How does early detection using these tests, these biomarker tests, how is it going to benefit your quality of life?
Well, I think it's an excellent question. And it really, I think, depends on the individual and how they would take that information, right? So we know that there are many people in the community walking around that have a lot of amyloid in their brains and are perfectly normal. And they may be that way for the rest of their lives. And so just because you have amyloid in the brain doesn't mean necessarily that you will develop cognitive problems later in life. But it does put you at higher risk. So if that's information that would be helpful to you, again, we're talking about this in a setting of if someone were to test as, they're normal, right? Not if they're coming into the cognitive clinic, if they're having problems already, that's a different scenario. We're just talking about if, someday down the road, if this were a screening test, how are we going to use that type of information? And I think that's an important question. It depends on, again, like I said, how we would use that information and how an individual would use that information on the road. You can go get genetic tests right now for ApoE, right? And like 23andMe that will tell you your ApoE status and whether you carry the risk allele for Alzheimer's disease. And so some people may want to know that, some people may not want to know that. And I think I think these biomarkers will also present the same type of questions, especially in the pre-symptomatic or asymptomatic stages.
So, Dr. Parker, you want to come on as we wrap up this session because you were in the chat firing off remarks to the 20 plus questions and comments. You want to give some context around some of your remarks?
Sure. For the moment, here at Emory, we do blood studies, blood biomarker studies, and we're usually comparing those blood biomarker studies to our actual treatment. So our actual treatments or evaluations consist of getting a cerebrospinal fluid analysis to look for amyloid beta and tau proteins. We might follow up as part of one of our research studies, compare the amyloid beta found in cerebrospinal fluid with what's there in the bloodstream. Somebody asked, well, why do it if you already know you have the diagnosis? It's just another way to perfect the tool as we move forward. We've got better ways of detecting lung cancer, breast cancer, and everything else. So this is just something else that we can do a little bit better. So there's a couple of questions in here. How can I get into the study? If you're interested in the Emory Healthy Brain Study, you can call Miss Latasha Chapman at 404-727-6050, and she can get you into the Emory Healthy Brain Study. Now, it says, I'm in the Healthy Brain Study and had both blood fluids drawn. Can you get the information from Dr. Law to help with your study? Dr. Law is the actual principal investigator and architect of the Emory Healthy Brain Study. And as part of the Emory Healthy Brain Study, we are taking the biospecimens that you give us and comparing your blood fluid biomarkers and your cerebrospinal fluids with controls. So as things become available, a lot of the specimens that you've already given us are already being used in comparative studies. We have an ongoing study with Washington University where we're comparing blood biomarkers, radio imaging biomarkers like PET scan results with the blood biomarkers. So we are using those studies. So again, these are different studies, but we're giving them there. There's another one in here. Is blood for precivity AD test if you're in the Healthy Brain Study? It may be part of the blood biomarker study that we're doing with Washington University. Okay, I don't mind giving a blood sample. Let's see, I'm in the Healthy Brain Study. Thank you, Jan T. And I just wanted to know what to expect. I don't mind giving a blood sample. I'm 84. Well, whatever it is you're going to give us, they're going to ask your permission to get it. So if you're already in the Healthy Brain Study, chances are they've drawn some blood from you, and they may be using it for genetics, but they may also be using it for biomarkers. Okay, for Robert and Carolyn asked, why do a biomarker test if already determined that I have Alzheimer's? If you're smart enough to ask me that question and type it in the chat, it's, again, a blood biomarker test right now. As Dr. Johnson says, it's not really clinically available. We are using it primarily in research. It's not yet widely available as a clinical tool. So we will be doing this, but right now you can look at the Precivity AD test online, and Washington University may be offering it. But for the most part, right now, to get the blood biomarker test, you're going to have to engage in some kind of research with a research institution. Some of these blood biomarker tests have not yet become commercially available, such that doctors like myself can order them and administer them to you. They're not available in that way just yet. It's coming, but it is not yet available. So I think that's it for me, Cornelia.
All right, I think we'll have to have a part 2 pretty soon to, again, clarify, but hats off to all of our faculty today. Thank you, Dr. Parker, for being available to help bring clarity to so many questions. We can do this over and over again and people will still have questions. So that's why you have to tune in each and every Tuesday. Remember, we will have a follow-up session coming in the coming weeks, but in the meantime, join us here next Tuesday at 2 p.m. for another session of BrainTalk Live. This session will be recorded. Thank you for subscribing to our YouTube channel, and we'll stay on a little while to provide additional web addresses and links that you need to jot down. We've given you Latasha Chapman's telephone number. She's going to be a great resource for you. Healthy Aging at emory.edu. That is a web link. We're going to drop it in the chat. But in the meantime, thanks for joining us, and we will see you back here next Tuesday. Bye-bye.